Welcome Bob Taylor to join us today. He's our visiting professor and scholar. He's the program director for the Georgia CTSA. He holds a PhD from Johns Hopkins and had an MD from Harvard Medical School. Did his training at Harvard Medical School and Boston's BI. After completing his training in cardiology at Emory, he joined the faculty of the Department of Medicine. He's the Marcus Chair in Vascular Medicine, the Executive Vice Chair of the Emory University Department of Medicine, the Director of Emory's Division of Cardiology, Professor of Medicine and Biomedical Engineering at Emory University School of Medicine. I'm really thrilled. Our interactions have been a couple times. One of the most important aspects is he does vascular biology. So even though he works on a different first name of smooth muscle, vascular smooth muscle, airway smooth muscle, we're bonded by looking at vessels with lumens. So with that, Bob, we're really pleased to have you here, and we'd love to hear what you could inform us about the Georgia CTSA.
Thank you, and I hope everything's coming across okay, voice-wise and picture-wise here. And thanks for the invitation. I will tell you, I started out in pulmonary. My PhD was at Hopkins, working with a group of pulmonary physiologists there, Saul Permit, and some of those old guys from a long time ago.
Oh, he's a colleague, a former colleague now, but wonderful individual. Wow.
Yeah, that's where I started. And then when I was in medical school, I actually worked with Roland Ingram and Jerry Mead up in Boston. And then I somehow got distracted by heart stuff. All righty. Well, thanks for inviting me. I must admit, I'm a little terrified about giving this talk. When I first got the invite, I thought, oh, well, I'll talk about some of our translational work and our science and stuff. And then, that's a fun talk and thing I've done a million times. And then Ray told me, no, you want me to talk about the Georgia CTSA. So here we go. I want everyone to raise their right hand and promise me they'll never serve on a study section that evaluates our grant, because I'm going to show you our dirty laundry. I'm going to show you our challenges, and I think we can learn by, I tell you stuff we've messed up and things that we are not doing as well as we should, and sort of challenges we've had over the several years. So I have to do disclosure. So I have some disclosures here. None of it's actually being discussed, but the other thing I do is I chair a conflict of interest committee. So I have to make sure that I do all of this, and none of this is discussed. My other disclosure is that I'm really a lab rat. I live in that T0 to T1 world, and part of my lab does transcriptional control of gene expression, and part of my lab does things that hopefully will end up in the clinic someday, and do some early human stuff too. So I'm at a different interface. I'm probably not your typical PI for a CTSA. And I finally said yes to this really to learn from you. I think the more I interact with other CTSAs, the more it helps us. And serve on some EACs, and I just learned so much from those. I say yes every time, because I sit there and take copious notes of things that I take back and to our unit. So this is us. Oh, and let me just say, if anybody has any questions, just interrupt. I hope this is conversational. I know there's a lot of people online, but just interrupt with questions. I guess we'll have time at the end, but if you have anything in the middle. So this is us. This is our last executive retreat. I will point out, for those who are in New Jersey, this was done in December last year. And we are standing outside, and it was about 60 degrees and sunny. As you can see, there are no leaves on the trees, but this is our group. And I like this picture because you can't find the PIs. You cannot find the leadership. This is just a group of people. It's a wonderfully diverse group, an enthusiastic group of people, and they really, really, really function as a team, which is the best part. Okay, so this is our history. So we're in, as Ray said, we're in year 4 of our 3rd funding cycle, and we are working on our 4th renewal. We've had bunches of meetings already. I have one of those exciting budget meetings this afternoon to lay out the budgets for next cycle. And as you know, it takes year and a half lead time to get one of these grants in. David Stevens, who's the medicine chair and our vice president of research, was the original PI. He was PI for the first 2 cycles. And honestly, I was pretty peripherally involved early on. Originally, we were the Atlanta Ctsi, Clinical Translation Science Institute, which was Emory, Morehouse, and Georgia Tech, so just in the Atlanta area. When I became PI with the 3rd renewal, we added the University of Georgia, and I'll talk a little more about that later, because that was a big lift. It was a great advantage, but it was a big lift. And then we switched to a multi-PI leadership plan, and that was very intentional, and I'll talk about that too. Those are then the 2 sort of cataclysmic changes for us in this 3rd cycle. So these are the PIs. I'll just introduce everybody. Henry Blumberg, who I think you guys know, and I think you're trying to drag into your advisory committee for your educational component. Henry's run our TL1, KL2 programs. Henry's an infectious disease expert and has done a wonderful job with our educational programs. And I'll say right now, it's really the crown jewel of our CTSA. The educational part has been incredibly successful, and a lot of it's just Henry and the team. They've just done a great job. This is me, the tall, bald guy. This is Elizabeth O'Feely. Elizabeth is a cardiologist at Morehouse School of Medicine, and Elizabeth is the PI for Morehouse. This is Andreas Garcia. Andreas is a mechanical engineer. Andreas is at Georgia Tech. He's head of the Institute of Bioengineering and Biosciences at Tech. And he is a very wet lab guy. He does a lot of cell and gene delivery work, very different. And I should say Elizabeth's focus is on disparities in both education and clinical practice. Now on the right there is Brad Phillips from University of Georgia. Brad's a PharmD, and at this time was chair of pharmacy. He's now moved into a larger administrative role in the dean's associate dean for research, vice president for research's office. And Brad's clinical interest is in sleep medicine. So a nice mix of folks with different backgrounds. And then this is just by background who we are in terms of our affiliation. So up in the top left there, that's the 4 institutions. We also are, what's our healthcare consortium? So it's Emory Healthcare, which is the main sort of clinical operation for Emory. We have affiliations with the VA and Grady. Grady is our city hospital. It is owned by the county, not by us. And we are, Emory and Morehouse provide clinical staffing there. It's a 900 bed facility. Morehouse School Healthcare is the PGP group from Morehouse. And then CHOA, Children's Healthcare of Atlanta, is our affiliate, but so our pediatric hospitals are actually under CHOA, not under Emory Healthcare, and we're affiliated. And then of course, within the state, we have important affiliations. The Georgia Research Alliance is a state agency that supports research, everything from entrepreneurial to startup packages. Georgia Bio is a organization of biotechnology companies in Georgia. And then of course, NIH and then CDC, then you've been to Atlanta. CDC is directly adjacent to Emory. And so that's a huge opportunity for us. And this group is going to grow in our renewal, as we'll talk about a little bit later. And this is our org. You probably have all these lovely org charts too, right? But this point is, this is our PI group. And then this is our executive advisors, which is the vice presidents of research from each of the 4 institutions. And honestly, they're variable involved. David Lee from UGA is extremely involved, and others variable amount. But we look to them for advice, and we look to them for funding, and work closely with them and meet with them every couple of months to really keep them in the loop and keep them up to speed. I'm sorry. And then this is our other, classic org chart. The only reason I put this up is to show you that our optional components are pediatrics and an innovation catalyst. Other than that, it's everything else that you already know. It's all those same units, and but these are our optional components that we focus on. And our innovation catalyst has really migrated really more towards an entrepreneurial catalyst, and really helps startups get moving and faculty build SBIRs, STRs, TTRs, and things like that. All right, I'm going to show you a cheesy video. Okay, this is, and the reason I show you this is what we, communication, as I'll talk about, is our huge problem. And so we have this little video, and we'll put it on a TV in front of when there's like another meeting going on, or we'll put it on a monitor somewhere and whatever. So I'll show you our cheesy video. Hopefully it works. It's not too noisy. Well, that's noisy.
We can't hear the sound.
Yeah, we don't, we can perfect almost everything, but you'll just have to imagine the music in the background.
So that's, we use that a lot. And it is a little cheesy, but it does get the message out about what we do, because one of our biggest problems, as I'll talk about, is just getting people, and Ray, you alluded to it in your introductories. What the heck are we doing, you know, and why is the CTSA here? So I'm going to do the good, the bad, and the ugly of our CTSA. And this is where you're all sworn to secrecy for any future CTSA review study sections, all right? So the good. One of our real strengths is our 4 institutions are very different. All right. So Emory is your classic sort of quaternary care, massive, giant healthcare system, right? We have, you know, 4,000 beds, 9 hospitals, you know, 50 outreach sites, just massive footprint through Northeast Georgia. Morehouse is a minority institution. It is focused on primary care, family practice, and urban health. Georgia Tech is an engineering school, strong engineering school. And then UGA is a land grant classic state university without a medical school. There's a medical school right next to them that's actually an extension of the University, Medical College of Georgia, which is not part of our CTSA. And but they are, you know, your classic, you know, giant school with football teams and all that kind of stuff. And so very different, and they all bring very different strengths. And that's, I think, really good for us. The other most important thing is our administrator, Andrew West. All right, so I have a pact. If Andrew ever quits, I am done. I will never cross the threshold of the CTSA offices again if Andrew quits. Andrew has been with us since the beginning, and he is now retired military reserve in the Marines and a logistics expert. So, and I am your classic disorganized scientist. So I definitely need Andrew. We all need Andrew, and Andrew is incredible. And he really is the glue that holds things together. We have support from the Woodruff Foundation and the institutions. So those of you Woodruff, translate that to Coca-Cola, right? The Woodruff family is the founders of Coca-Cola. Emory has been called Coca-Cola University before. I am in the Woodruff building. There's like 5 Woodruff buildings on campus. But that is an important part of our support. Although I will say, as I'll candidly tell you, they could do more. We're probably not supported as strongly as many other institutions. We have great diversity at all levels, trainees, faculty, staff, and that really helps us. We very much reflect our community, and that's an important part of our identity. Our faculty are incredibly engaged, and it hasn't always been so, but they are really engaged now. Sometimes I wish they weren't so engaged. There are a lot of emails flying around, and every time a new supplement comes out or something, the email box lights up and people start meeting, and it's a really engaged group, and that's very exciting. Our trainees are fantastic. And again, as I said before, it's sort of the crown jewel of our operation. We love what we do. There's really a good esprit de corps. And the other thing I'll tell you, the good has been COVID. And Ray, you alluded to this in your talk. It is a horrible pandemic, but it has been a time for the CTSA to shine. I mean, we've really been able to step up. Two of the things that we have been in, we've been involved in lots and lots of things. Two of the sort of the highlights, or three of the highlights, we're very involved with RADx, obviously, and as a testing site and with our engineering colleagues, et cetera. I think the other two things that have really helped us, and we've been able to help the institutions, is that one of the key things is getting studies approved. So prior to this, because of our experience with Ebola, we had developed a rapid approval process for a crisis situation where we could take a clinical trial or a clinical study from day 1 to day 2 with the idea to get it approved and up and running in 48 to 72 hours. And I can tell you right now, we've done that with 30 studies during COVID, the shortest one being about 36 hours from paperwork to ready to enroll first patient. And that's been huge. So we've been able to get up the vaccine trials, the remdesivir trials. So Emory was the affiliates were the largest enroller in the world in the remdesivir trial. And we got that approved in 36 hours from start to finish. And that's really been an important thing. The other is we've been able to work with CDC and FEMA and do really large scale antibody screening on their workers. And that was another thing that we set up 3 days, 4 days. We found out on a Friday, we were ready to go on Wednesday with a blood drawing center, complete with staff and the whole courier service and everything else. And of course, that was all Andrew, our logistics expert, put all that together. So, and there are just many other examples, and it's really, I think, helped our reputation within the institutions and demonstrated our value. And of course, really helped our patients to get all these trials up and running. All right, the bad, where do we struggle a little bit? We have 4 institutions. I told you that was a strength. That's also a real problem, and just like it, we have public and private. We have different funding cycles. We have different, all sorts of things. Georgia's a poor state. The Atlanta metropolitan area is very different than the rest of Georgia, but Georgia is in the bottom 10% of the country in terms of income. We have incredible poverty in the state. And there are huge healthcare disparities in Georgia. The other bad is there are way too many meetings. If I get one more call from NIH saying, oh, we have to have another meeting with Ncats, and, there's just, Ray, you've probably enjoyed many of these meetings as well. Lots and lots of calls, and you're like, why am I on this call? Why are we doing this? A lot of that. The other bad thing is really getting everyone on the same page. And Ray, you alluded to this as well. We're a service organization. Getting everybody focused on that is a big deal. It's hard to forge new interactions between schools. While we had some pre-existing relationships, there was a lot of distrust, a lot of, well, the big school's going to take all the money, or, we're just on here as, I heard the term, we're your arm candy. I loved hearing that from a colleague at another institution, and really getting people to build relationship. And then the other thing, as soon as you're funded, and I'm sure you've not had this experience, everyone shows up to you with an open hand and says, source of money, why don't you give me some of your funds? And, they don't realize you actually have a budget that's pretty committed. So the ugly is, we still have 4 institutions, and that is one of our challenges, and not everyone gets our mission. We have communicated until I've communicated and met, but some people will still walk up to us this day and say, I don't really know what the CTSA does. And that's been our biggest challenge. And like nobody knows what we do. It's amazing. The chair of a department in a school of public health, who's been here for 30 years, said to me the other day, about a couple of months ago, I'm not really sure what you do. So here's a chair in our school of public health who doesn't really know what we do. And then this again alludes to something you mentioned, Ray. we had to really, with this cycle, really have a culture change. And my mantra was, this is not your mother's R01, right? This is not about your publications, even though NIH counts those carefully, right? Ncats very carefully counts how many publications we put out with Ncats on. This is really about being a service, being an infrastructure, facilitating an educational resource, and just trying to get everybody to understand that. And that's a point we've just keep hit on every time we meet with all the groups, all the members of the CTSA. A lot of money from the NIH is never enough. We're a big CTSA. Our budget is about $8.5 million a year, and that's a lot of money. And boy, does it go fast. I mean, we never have, and as you know, administratively, you're not allowed to carry forward with these things. It's never been a problem. That money is spent, and with a large organization, it goes out, and that's good, but it's never enough. There's always things we want to do that we can't. The other challenge, and you've not experienced this yet, but be prepared for it, is Ncats funding gaps. And I hope not too many people from Ncats are listening, but we had a huge problem between cycle 2 and 3 in that. So we submitted our proposal in June of that year, in June. It was reviewed in October, got a good score. We were told from a program officer, slam dunk, this looks great for our renewal. Council met in January. They elected not to fund anybody but Vanderbilt, who was in our cycle, and the rest of us were put on hold. Our grant ran out in July. So comes July, still no notice of award. And they waited until the 3rd week of August to do an NOA. And so we had a funding gap, and we had an uncertainty about the continuation. And honestly, to this day, I don't think Ncats leadership understood the impact that has on an operation to have, because we lost people, we lost coordinators, we lost faculty. That was a real challenge for us. And that was a period of time, candidly, when Chris Austin was considering reducing the number of CTSAs and was trying to divert some more of the funds internally to Ncats. There was some interesting communication to him from Congress, reminding him that the number of CTSAs is actually mandated by Congress. And so there was a lot of stress and anxiety among the PIs at that time. And we were out of money. And, when you're getting $8 million a year and suddenly it stops, you have a lot of salaries that stop getting paid and everything else. And there was no certainty about what was going to happen going forward. And that was a huge problem. And COVID has obviously been, while it's been helpful and helping and allowing the CTSA to be functional, it's really, really been tough on all of us for many reasons. Okay. So I'll talk about some problems, alignment and synergy. So I went to all the other PIs and a bunch of leaders in CTSA, and I said, oh my God, I got to give this talk in New Jersey. So tell me what you think the #1 challenge we have. And they're all like, alignment and synergy, getting 4 schools on board to do the same thing, to understand. And, 3 different people said the same thing to me. Make sure the whole is greater than the sum of the parts. How do we make sure we have true synergy? And as I said before, Georgia Tech, UGA, giant, huge state schools, different fiscal years, huge teaching mission, right? Everybody's in teaching, both are huge. Morehouse, smaller school. Morehouse has about 200 permanent faculty. It is a tiny medical school, and it is an important medical school. It really has an important mission and brings a lot, but they get dwarfed. Emory is a much more research-focused, large healthcare system. We're 3,200 faculty or something like that in the School of Medicine alone, and then we have a School of Public Health, university, law school, et cetera. New PIs, all right, so I was new. Andreas Garcia was new, Brad Phillips was new. So you have 3 new PIs who have never done this before. And honestly, there was a lot of distrust. There was a lot of distrust between the schools when this started. Is everybody on the same page? Are we getting our fair share? There was some initial discussion. Well, should we just give out money based on what % of the, what your relative NIH budget is? Well, that's probably not a good plan. because Morehouse would be incredibly disadvantaged by that, by being a small school and a school that we're supposed to be helping. We're supposed to be adding to them, and we're helping move that school along. So a lot of that was a problem. So how do we bring these schools together? So the multi-PI team, I made the decision against some strong advice from other people to do a multi-PI team. And that was a gamble. I mean, because Emory had owned this for 10 years, right? This was our PI, our grant, our Ctsa. And the previous versions, they were co-investigators at the other sites. But it was clear they weren't as involved as co-Is. And I'd had a lot of experience with multi-PIs and R01s and stuff. And I'd run a biomedical engineering research partnership before with multi-PIs, and I'm sold on the multi-PI model for engagement. And so that was a gamble, but it's a gamble I think that has really paid off for us. We build upon some previous relationships. So Emory and Georgia Tech have always been very close. We share a department of biomedical engineering. I have an appointment in biomedical engineering, a dual appointment there. And we just, we have students going back and forth. UGA was a bit of a stretch. Morehouse has been an okay relationship in the past that has grown much stronger in recent years, largely because of the Ctsa. The other thing is I went and twisted a friend of my friend's arm. So Andreas Garcia at Georgia Tech is a longtime collaborator, head of this IBB, this Biotechnology Institute. And the previous PI was leaving. And the previous PI told me, yeah, I just take the money and use it to fill in the gaps. That's how he handled his subcontract to Georgia Tech in the past. And again, this is why you're all sworn to never serve in the study section, because this was his MO. And I said, we're not doing that in the future. This money has to go for what we want to do. And Andreas was on board for that. And that has been absolutely key to have that person buy in completely, understand the whole thing, and contribute incredibly to the progress. And then we got lucky with UGA. Brad Phillips, the PI from UGA, is spectacular. He lives, breathes, and dies the Ctsa. I mean, he's totally engaged. And then the vice president of research at David Lee at UGA was completely open. I'm a little terrified. He's retiring this June, and so they have a new search. Always makes me a little scared. But David was critical. He came to every meeting. He threw resources at it, and he made sure it happened at UGA. And that was really important. And lots and lots and lots and lots of communication and contact, and a focus on our points of synergy, not where we duplicate each other, but where the two or three or four parts can be better. And we do lots of joint activities. So I'll tell you about our joint activities. So this is again, just to point out that our team we meet a lot, and I'll talk about that specifically. This is us at one of our retreats for our meeting. So we have PI meetings, monthly, remote, and quarterly face-to-face. So that's the 5 PIs. Every month, even before COVID, we'd get together by Zoom. And then every quarterly, we'd either go to UGA, Morehouse, Emory, or Georgia Tech and sit down and just work through everything and have a 2 to 3 hour lunch meeting and go through it. And we obviously communicated a lot in between. We have monthly meetings of our program leaders, and we revamped this whole thing to make it really integrated, to focus on synergy. And so we do some general business, what's going on, who's over budget, that kind of stuff. And we celebrate collaborations. And then every month, 4 of our cores or programs give their 10-minute elevator speech, what they're doing, what their aims were, what the progress they've made, the multi-directional synergy. So synergy across institution and between cores. Where's their synergy? What have they developed? Where do they need help? And then we also do budget burn rates. And that really helps because everybody's on board. All the program leaders, core leaders are there, and we talk about this. We do these things called blue sky meetings, and I'll show you some examples of this. And this has been a huge success for us. And what we do is we pick research topics, and they can range from rural health to the microbiome to we're doing one on drone delivery to rural sites, all these crazy things. And we bring groups of 10 to 20 people together from the 4 institutions plus other people from other sites. And there's no agenda other than how can we work together? And the goals are grants or courses or papers or whatever. And so they're very open. Some die a quick and painless death because they don't work. And some are very successful and they lead to grants, collaborations, all sorts of interesting things. Now I'll show you some examples. We do a lot of speed dating things to build collaborations, again, around a topic. We did one on sepsis a few months ago, where we had way too many people show up. And everybody spends 5 minutes with somebody and then talks to somebody else, and you move down the table. And now, and then this was David Lee's big contribution. So when we were writing the renewal, David Lee called me up, and he's the vice president of research at UGA, and he said, "Well, where's your meeting?" I said, "Well, which meeting? We have so many meetings." He said, "No, where's your science meeting? You don't have a science meeting." And I said, you might be right, David. We actually, in our morass of hundreds of meetings, we don't have a regional conference for us, for state, or for our CTSAs. And we started that, and I'll talk about that too. And that has been big for us. All right, so what are the things we do to break down these silos? So speed networking. So here, there's some examples of ones we've done on opioid, one on obesity, diet, and exercise. Blue sky groups, we've done a software one. Extracellular vesicles, that's a little unusual for a CTSA. It was actually a lot of fun. A lot of people got interested. That drifted a little more towards like T-0 basic science, but it does have some clinical applications and actually spun some grants out. And you can see the other topics. And then we do actual training in team science. So the CDMTS group runs courses and workshops in team science on how to work together, and we bring in some experts, and we bring in people with experience. And we were I was personally a little unsure about this, but it has worked very well. This has been well received. Then we also do a health services research day, and I'll show you a little flyer on that in a minute. But we bring together people who do health services research, present abstracts, keynote speakers, and again, from all of the, and this is really focused on the 4 institutions, whereas our statewide conference is bigger. So this is our regional conference, or statewide. So it started out as just sort of the 4 institutions, and then we expanded to other places in the state. And then last year we invited the CTSAs from Florida, Alabama, and South Carolina to come join us. And we've had some good representation. This year it's going to be virtual. We'll see, but we've already just finished the abstracts. It's going to be in the end of February. And we actually, a former postdoc from UGA who's in Ghana has submitted 7 abstracts. So we now can claim an international meeting, but it's your traditional sciencey meeting, with posters and things like that. We give out awards, and we give out awards for team science, the President's Award for Distinction in Team Science, and Team Science Award for Early Stage Researchers. And the presidents of the universities actually sort of make this decision. We might actually give them the list and tell them, give them some advice, but it's a President's Award, and that's actually pretty cool, and people like it. And they get a little glass peach with a President's Award and some cash for the team. And this is one of the flyers we put out, and you can see we had Mike Carilla come down. We always try to get somebody from Ncats or NIH or as one of the keynotes, but then bring in other keynotes as what we've learned over the years. This is the one from 19. We do it at most recently we've done it at Callaway Gardens, which is about an hour south of Atlanta, hour and a half south. So everybody has to come, and we do it just a 2-day thing, a day and a half. And you can see this year in 19, we had those universities from Georgia. And then when we did it earlier this year in 20, we included UAB, Florida, Miami, MUSC were involved as well. This is our health services research. This has also been really helpful, really trying to bring together and develop people in the health services research. And again, this is more focused on the 4 partners, although others are welcome to come, but that's the focus, is really the 4 partner institutions. The other thing that's really is we've gone sort of over the top with interinstitutional agreements. Now some are required, right? ACT, TIN, all those are required, right? But we've gone sort of over the top on this, and this has been really helpful. So we have MTAs between the institutions. We have some software licenses. We have this Georgia core facility, and this is really not, I can't claim all of that. This core facility MOU, that is really something that we sort of jumped on and helped facilitate at the end, but it was really more of a grassroots thing between all the universities in Georgia to share core facilities at the internal rates. So somebody from Augusta University can come to Emory and use our proteomics core at the quote internal rate. And that's been helpful. And then these data use agreements, IP agreements between institutions, et cetera. And then I guess what's not listed here is we have reciprocity for our IRB, which is really important. So these have been key to building credibility. And this is an old slide. They're all green now. We don't have any yellows up there anymore. And then we measure everything. And Ray, you alluded to this too. You know, as painful it is, you got to measure stuff. You got to figure out where you are and look to those connectivities. So we have a wonderful evaluation group. And this is just they do a lot of network evaluations. They do all these network maps. We look to see how we've grown. And this is just sort of a high view that we did early on for an EAC to show them between 17 and 18 as we were moving into this new phase. And that's why I pulled up this old slide, that we originally only had about 30% of the programs at all institutions, and now we had 50. Now it's more like 65 or 70. Not all are there. I mean, Georgia Tech does not need a pediatric link, obviously, but just to make sure that we're looking at these programs or cores and that they're across the different institutions. This is another thing we did, is looked at opportunities available. So things that people can use, and it's just not cores, it's just things that they can use at different institutions. And it's not just the 4 core, we've spread this to the state. So if you need some 3D fabrication, you click on this link and there's some people at Georgia Tech that can help you with it. And it's a searchable database with about 200, it's 182 now, it's over 200 entries now. The other thing we've done is to make sure our clinical research groups talk to each other. So we have these 5, these are all the adult ones. So Emory runs these 3, Clifton, that's our main campus, Grady, our city hospital, Midtown, our other major hospital. And then Morehouse has one, and then University of Georgia has one. So they meet every month. They have this reciprocity agreement. So UGA is big on vaccine trials, which has been very helpful lately, obviously. And so some of their trials actually run in our Ctsa, we had an unfortunate situation where we called it something else and we got sued because of infringement on the name. And so we had to change the name. So we now call them the Georgia Clinical Research Center. And unfortunately that turns into GCRC, which is you can't use those letters anymore at NIH, but that's what we are. We call them GCRCs. So they all meet every month and share protocols and problems. And then we actually have between us and Morehouse, actually have an employee sharing agreement. So if Morehouse has a bump in the number of studies and they need an extra couple of study nurses, we have a loan agreement where we can, quote, loan a coordinator or 2 over to them. And then Pediatrics they're part of that too. This is just separated by adults and children, but our CHOA group is huge. They have very large outpatient and a brand new one that just opened for their, and they have 3 sites for their clinical research. We do some targeted investments, particularly to bring the engineering school on board. So Capstone Design, so engineering programs all have capstone projects. The students in their last 3rd and 4th year have to form a team, solve a problem. Well, we fund some of those teams. We make a contribution to that. This year we won. This team developing a catheterization kit, an adaptive catheter that helps with catheterization, ended up getting patented and everything else. Turned out to be an all-female, very diverse team. Huge success for us. And so that's just a way of showing how the CTSA can interact with an engineering school. And in addition to the money, we obviously contribute medical expertise to those teams. We do a lot about entrepreneurial, and this really resonates across the system. So this is the Kaufman Fast Track. This was the one in 17. We do this every year, which is for entrepreneurs. We supplement it along with the Georgia Research Alliance. So this of course normally costs, I don't even know how much, but we charge $150. Yeah, that's what the cost is, normally $800, but we subsidize it. And so people pay a little bit, so they actually show up, honestly. But this is a very popular and often fills beyond its capacity, and it helps our entrepreneurial activities. All right, our second biggest problem, I'm going to watch my time here and make sure I finish up and give time for questions. Communication. All right. I found out from the president on down, when I took over, really had no idea what we do. They just didn't really get it. And people think of us just as a funding source. A PI at another CTSA told me once, the university will only realize how important a CTSA is if they lose it. You are taken for granted. And so you're in the honeymoon phase where they still love you, but in the next cycle, you'll just be, well, they're always there, and I think this little bit of cynicism from this other PI has resonated with me. We had a lot of PIs that think we're only for new investigators. Why would a full professor ever need any of this stuff? And many don't know what we do. So when we got renewed, we did the Georgia CTSA Roadshow. So we made this standard slide deck for PIs and administrators to present. And we went to deans and presidents, departments, clinical units, anybody would have us come. Faculty orientation was a really good opportunity for us. And it's a 15-minute, 10-minute talk with that little video in there. And we talk about what we do, talk about the educational programs, and then have some face-to-face time to build relationships. And we found this really helpful. And people that we thought knew everything that you should know about us didn't know anything about us. And that was really revealing to me. We do a e-roundup newsletter that goes out every Friday. And we have about, as you can see, over 3,000 subscribers at last count. And Amy is our communications person, does this. It's always fresh. There's no regurgitated things. It's new every week, which is a lot of work for Amy, a lot of time. It has funding announcements. It has some stuff, but it always has a lead story about something unique with the CTSA and what we're doing. So, and that's been well received. And a couple other CTSAs have, asked us to spend some time with them, helping them get it up and use a similar format for their site. We've really worked on email management. We have very limited emails we send out. We really focus on that Friday email e-roundup. It's very few system-wide blasts. We have some specific listservs for like the PIs or the program leaders. And then we link to institutions. So we learned early on that if you send a lot of emails, people stop listening. And so you have to be very focused in what you do. And then the website, and our website just got revamped because it really wasn't very good. And we spent a lot of time and a fair bit of money to make the website better, we hope. I looked at your website. Your website's really good. You have some really good ideas in there. I like your website a lot. Your little vignette at the bottom where you show stories, videos, I think it's a really good idea. And it's, we get a lot of hits. And the main thing is we want to make sure people can log on. And there's basically, you can say, I've got this problem, and we have a navigator that handles that and then funnels them to who they need to go to. Someone logs on and says, I need help with biostats, or I'm a new investigator, I've never written an IRB, or I want to learn how to use the GCRC. The navigator takes that, and she either sets up a meeting with that group or connects them directly to the people that need to be connected. And then communicating up. Proving our value to the big guys, right? So we have an annual president's presentation. So we invite the university presidents, a smattering of deans and other high-level leaders, and give them a 1-hour light presentation. The first time we did it, we ran the list, and you guys have probably fallen into this trap too. Well, we got 12, 15, whatever programs. Let's run the list. Well, after about the first 3, the entire group is sound asleep. And instead, we've done in recent years vignettes, and we talk about success stories and places where we've made the schools better, where we've made the schools integrate with each other. And then we invite key leaders, department chairs, VPs, et cetera, so they can work and get time with the presidents. And so we actually get really good attendance at this because it's a good networking opportunity. And we invite people from the community, et cetera, as well. And all the PIs lead in. It's not just me. We truly share the leadership of that meeting. And that goes well. And that helps us communicate up. And the things we can communicate to them is, exactly what you would think, right? How good are the pilot grants? How much money did they bring back? We communicate impact, 3,200 publications we have. We've been around for a long time, 13 years. How many citations, and how does it, lead out to, news stories, policy statements, patents, things like that, demonstrating our impact, again, sort of managing up effectively. All right, problem 3, making the education program span 4 institutions. UGA is 2 hours away. The hub of the MSCR program has been based historically at Emory. Morehouse has a tiny training program, and it was totally new for UGA. They didn't even know what an MSCR was, and why would anybody want to do this? And UGA had a very small school of public health, and there was some distrust of this monster, 3-building university, Emory School of Public Health, coming on board. And then, why would engineers want an MSCR and we offer a certificate in clinical research too? Why would they want that? And we have to sell that to them. And key efforts were lots of communications. Henry is amazing. He has this incredibly organized application process. It starts with some seminars by PIs, an experienced editor, really a grant writer works with them. They do pre-review of the applications. They give them a chance to revise it after the initial cycle. And they continue to work with applicants to close, even if they're not going to get a KL1 or KL2 or TL1 slot, to help them move into a K slot or an AHA pre-doc or postdoc or some other thing. And then every year we submit a couple of minority supplements. And he does roadshows. Henry does roadshows. He takes it out, and we meet with people and we try to get them on board. And COVID has really, so this is dirty laundry time. Henry was dead set against any sort of remote learning. He thought everything had to be face to face. Well, we got a supplement that started all of this to work on remote learning with UGA, and we put 1 course into it, or 2 courses into that, an epidemiology course, and I can't remember what the other one was. And then then COVID hit, and we went totally remote, and that's been fantastic, because in the future, I guess we'll have some in person, but I think we're going to be largely a virtual MSCR in the future. And then, just selling it, and how the people are and what they've done. All right, statewide impact. That's a challenge for us. We were focused, this original CTSI was just Atlanta rather, and it's very different than the rest of the state. The state of Georgia has a heck of a health problem. We're number 2 in the country in maternal mortality. We used to be number 1. We're 8th in stroke, 3rd in Alzheimer's, 6th in kidney, 15th in heart disease. We have huge public health problems here, and we're struggling. We are struggling with that. How do you get out of the city? How does the big institution have an impact in a county with 600 people? In the first, a lot of people said, oh, well, we'll set up clinical research sites. Well, that's not what you're talking about. You're not going to do a drug trial in Harris County, with a population of 3,000. That's not what it's about. And we really need to better align with the extension service of UGA. So UGA has an extension service, and we've always thought of that as, well, that's where you get your lawn tested for nitrates and stuff like that. But their primary mission is education, and that's been really helpful to us, and we're starting to make some real inroads there. We needed to expand our very successful community engagement program. That's actually been one of our other really important and successful programs, but it's been focused really largely on the Atlanta area. So how do you expand that to rural? How do you bring UGA and ISP and all those pieces together to get out of the city without destroying what you really had, a very robust community engagement program focused from Morehouse, largely based in Morehouse. And how do we do that? And that's what we're struggling with, honestly. Okay, last 3 slides or so. Dirty laundry, case 1, what we tried trouble with. All right, clinical research unit problems at Emory University Hospital. Staff developed a culture of entitlement, not service-oriented. I got answers like, well, we've always done it this way. And who does she think she is bringing that trial in here? And we have a process. And so they'd been around since the early days of GCRC. We had some folks there that would say have some mileage on them, and had always done things. And our customers were not happy. We were not meeting their needs. We did a customer survey, and they were not happy. And so we had to fix this. So we actually did customer service training, regular commercial customer service training. We had selective restructuring of the staff, as they say, and then we made sure that people did jobs they could do. And we also, as part of our last renewal, did an entire business analysis of the GCRC to really understand how to make it work better financially. And so that's been really good. That's really good. And, I'm proud of how it's grown over the last several years. And so that's moving along nicely, but it's still a work in progress. Case 2, pilot grants. All right, when we looked at it, the majority of the pilot grants were coming to Emory. And the president of Morehouse called me up, and my ear is still ringing after that phone call. She wanted to know why over the last 4 years has there never been a PI from Morehouse School of Medicine. All right, we got 3,000 faculty. They have 200. There's 2,000 at Georgia Tech. The numbers are against them, but why had there never been a PI? Well, they're largely a younger faculty. They're a faculty without a lot of research experience. How can we make this better? So we started workshops at Morehouse with Emory and Morehouse faculty. We provided some additional editorial support. We offered pre-review grants if they finished in time, and often people didn't. And then starting this year, we're going to do a score boost for PIs involving 2 or more institutions to really build synergy and to build connectivity. But I will tell you, over the last 2 years, we've had multiple grants funded with Morehouse PIs, and that's been a positive. But that's, again, a work in progress. The other thing is, what's translational research? We've had some interesting discussions, I will say, about what is translational research. Where is that boundary between T0 and T1? And you can suspect, you might expect I'm a little sensitive to that issue since I live in that domain. And some other people came, well, we shouldn't fund any animal studies and pilot work grants. We shouldn't fund any animal studies with our TL1 or KL2s. And I said, well, we absolutely should. And so that's ongoing. We've sort of resolved this. We have, I guess, a gentle truce, but there are some biases, and that's a work in progress for us too. And so with that, I'll just say thank you. I really appreciate the opportunity, and I'm open to questions. I hope I didn't take too long. If any of you want to talk to any of our program leaders, just reach out to me. I can connect you. You know, if you want to talk to our ISP or community engagement, whatever, they're always open to sharing ideas, because they'll get as much from you as you can from them, or maybe more, because this interplay between the institutions and the CTSAs is really, really helpful to all of us, I think. And with that, I'm happy to take any questions you might have.
Great. Well, you know, Bob, I want to say that talk was absolutely perfect for what we wanted. You couldn't have done a better job. And I don't usually so effusive to a cardiologist, but you never trust one organ. You got to have paired organs. But the point here is that was spot on. I mean, you were able to share with us your beginnings. The struggles we hear are exactly the same struggles we have, exactly the same struggles. And, you know, the symmetry amongst the institutions in JIT, Princeton, and Rutgers is very similar. And I think you've helped us clarify, because sometimes when you're in the trenches, right, you feel you're the only one fighting the war, and you don't realize that every other hub has been there. And I applaud everything you just said, Bob. This is wonderful. We hope that we can build collaborative efforts here. And the chat box is just filled with accolades. I'll send them on to your president if you want. We have a new one, by the way.
We do too. We have a president who just started, and his administrative assistant sent me an email and said, why should he come to the president's talk next month? And I said, well, because it's entitled The President's Talk.
Well,
I guess there's a question about the lawsuit. I'm happy to answer that. So,
yeah, go right ahead.
Yeah,
you can selectively pick some, but the accolades.
Yeah, we had a question about, so we got sued for calling it the Clinical Translational Science Unit, CTSU. And apparently there's some guy somewhere that has copyrighted or whatever that name. And we got threatening letters from lawyers, and they were preparing a lawsuit. And, and so we actually avoided the lawsuit. It was never filed, but we had to negotiate. We had to have our lawyers negotiate with them. And we went through 3 or 4, it was really stupid, they weren't even in the state of Georgia. It was a ridiculous, frivolous thing, but we had to negotiate a name that they would like. And the name that came up was the Georgia Clinical Research, GCRC, Georgia Clinical Research Center. And of course, as soon as we agreed to that, got the lawyers to sign all the papers, our program officer from Ncats said, Joan, who used to be your program officer, I guess, right?
Yeah,
Joan said,
Joan,
what are you doing? Why, how on earth could you call it the GCRC? that is a dinosaur from the past, and that's going to be terrible. So we call it GCRC internally, and then we use the full when we speak to NIH, because we were not going to go with that again. All right, let's see. How did you deal with labor issues with a staff rental? You mean with
shared personnel between the CRUs, I think.
Yeah.
Yes, yeah, exactly. You know, like we have different unions within even our own system. People crossing over, how you sort of, you know, I think that's a wonderful staff flexing model. And I was curious how you were able to do that across institution.
Well, we don't have any unions. That's one thing. And then we have a quote rental agreement. That's a terrible term, isn't it? To rent a human being. But we do have a rental agreement. And then we're actually set it up internally, actually for new investigators too. So a new investigator, for example, who wants to get a trial up and running and needs a research nurse or coordinator to help them with the documentation, you know, we'll share them for, you know, X number of hours to help them going. But yeah, it hasn't been too hard because we don't have any unions or anything, you know, that makes it easy.
I'd like to just focus some of these because of time.
Yep.
I think Al brings up a good question. Can you tell us a little bit more about the land grant community extension program? We're a land grant university also. How did that work?
Well, it's under construction very much, I have to say. I think the challenge is I can tell you many investigators at Emory thought, oh, great, they have a extension agent in every county. I'll do my clinical trial in these other counties. And of course, that's like not a good idea, right? That's not the whole point. And their mission is education, right? Their mission, they have these education programs. So we had to figure out how to help them. So we said, okay, first of all, let's not take from them. What can we give them? So our community engagement has done this now, 3 or 4 times, run grant writing classes for them to apply for state and regional grants with community-based organizations that worked with the Extension Service and the community-based CBOs to work on that. And then I think more importantly, in our last couple of strategic planning, we've worked with the leadership of the Extension Service and trying to find from them what the big issues are. What can we do for them? What do they need? And so as we're working on a renewal, for example, so we've actually never had a theme for our CTSA. We've never had a theme. And in our renewal, we have a theme on healthcare disparities, because that's really been our theme without ever saying it. And in the rural setting, you know, how can we work on these disparities? So it's really been, you know, what do they need? What can we provide them? And then we've done, our ISP group has worked with a couple of communities on very specific programs through faith-based organizations around education, one in case of prostate cancer, and another one that's developing in maternal health. And so that's been sort of us readjusting what the needs are through the Extension Service, not us saying, what can the Extension Service do for us? And that's been sort of the big flip there.
Just 2 quick questions, and then we're going to move on. There was one question. You have 4 institutions. Do you think 8 would be better and 12 would be best?
No, in fact, so here's another sort of difficult. So Augusta University, or Medical College of Georgia, approached us about joining, as did, and we said no, because when I talked to Mike Carilla, I said, you know, we're getting pressure from them. And he said, don't do it. Don't do it. You are too big now. This will not go over well with review panels. Help them build their own, but don't do your own. Don't bring them in. You know, so we have affiliates. So Mercer has a pharmacy school that is going to be an affiliate, but I think 4 is more than enough. And I think there's actually, good wise words from Mike that, we probably
I agree. I think adding an institution is not a multiplier. It actually adds 1 log, more confusion, and disparity.
And I think the other important thing is the other institutions have to be unique. They can't just replicate what you do. So Augusta University does a lot of what we do. So they're better off as a separate one. And I just signed the letter of support for their application the other day, that we'll share some resources and share some of our training and state conference and stuff like that. So yeah.
Very insightful. The last question is, we have a very robust environmental health and exposure community and institute, EOSHI, and so do you all. How have you built that into your CTSA? Has there been sort of a pathway pipeline for environmental exposures and the consequences on health?
I'd have to admit, no. I mean, we've had a couple of, I know there was a KL2 scholar, who, was in that group, but there hasn't been honestly a conscious effort. That's probably a good opportunity for us. But
yeah, we tried to develop a working group on that to connect some of the CTSA hubs, as we see the environment is so important in imprinting and genomics and epigenetics. So, I mean, I think that's it. Well, I want to take this moment to thank you, Bob. That was just outstanding. Wonderful job. Thank you so much.
Thanks for letting me come. And I'm going to hang around and listen. And I'm taking notes already, and I already wrote, why aren't we involved with the environmental people? And that we're going to do that as a blue sky group this spring. That's a good idea.
Great. Well, I'm sure Howard would love to come down to Georgia virtually. So that's Howard Kippen I'm talking about. All right. So